Welcome to today's discussion on amphotericin B nephrotoxicity, a serious kidney condition resulting from the use of the antifungal medication, amphotericin B. We'll explore its causes, mechanisms, symptoms, diagnosis, treatment, and ways to prevent this complication. This information is for educational purposes and should not be considered medical advice. Always consult with a healthcare professional for diagnosis and treatment. Amphotericin B nephrotoxicity is primarily caused by the drug itself. Amphotericin B is a potent antifungal medication often used to treat severe systemic fungal infections. While highly effective, it has a well-established side effect of damaging the kidneys. The risk increases with higher doses, longer treatment durations, and pre-existing kidney conditions. Certain other medications, such as aminoglycoside antibiotics or diuretics, when given concurrently with amphotericin B, can also increase the likelihood and severity of nephrotoxicity. The underlying mechanism involves several processes. Amphotericin B binds to ergosterol, a component of fungal cell membranes, disrupting their integrity and leading to fungal cell death. However, it can also bind to cholesterol, found in mammalian cell membranes, including those of kidney cells. This binding results in several detrimental effects on the kidneys. Firstly, it increases the permeability of the distal tubular membranes, leading to a loss of potassium and magnesium. Secondly, it causes renal vasoconstriction, reducing blood flow to the kidneys and leading to cellular ischemia or reduced oxygen supply. Thirdly, it can directly damage kidney cells, leading to tubular necrosis. All of these factors contribute to a decline in kidney function. Amphotericin B nephrotoxicity is a common complication, particularly in patients receiving high doses or prolonged courses of the drug. Exact epidemiological data is difficult to ascertain because the incidence varies depending on the patient population. The dose and formulation of amphotericin B used liposomal forms are less nephrotoxic, and other risk factors. It's estimated that a significant proportion of patients receiving amphotericin B will experience some degree of kidney impairment. Immunocompromised individuals, patients with pre-existing renal issues, and those receiving concomitant nephrotoxic medications are at particularly high risk. The signs and symptoms of amphotericin B nephrotoxicity can be subtle initially. Common symptoms include decreased urine output, often signaling impaired kidney function. Electrolyte imbalances can manifest as muscle weakness, cramps, or irregular heart rhythms, particularly from potassium and magnesium loss. Patients might experience fluid retention, leading to swelling in the legs and ankles. In severe cases, there can be a build-up of toxins in the blood, causing nausea, vomiting, fatigue, and confusion. It's important to monitor for these signs during amphotericin B treatment. Diagnosing amphotericin B nephrotoxicity involves careful monitoring and assessment of kidney function. Serum creatinine and blood urea nitrogen (BNN) levels are typically measured regularly to assess kidney function. Elevated levels suggest impaired filtration by the kidneys. Electrolyte levels, particularly potassium and magnesium, are monitored to detect imbalances caused by tubular damage. Urinalysis can reveal protein or other abnormalities in the urine, indicating kidney injury. A renal biopsy may be considered in some cases to evaluate the extent of kidney damage and rule out other causes. While there aren't distinct types of amphotericin B nephrotoxicity, in the same way you'd classify a disease, the severity can range from mild and reversible to severe and potentially irreversible kidney damage. The extent of kidney dysfunction is often categorized based on the degree of creatinine elevation from baseline, or the estimated glomerular filtration rate or eGFR. Also, liposomal formulations of amphotericin B tend to cause less nephrotoxicity compared to conventional formulations. Management primarily involves supportive care and strategies to minimize further kidney damage. Discontinuation of amphotericin B, if clinically feasible, is often the first step. Intravenous fluids are administered to maintain hydration and improve kidney perfusion. Electrolyte imbalances are corrected through supplementation of potassium and magnesium. Sometimes medications like amiloride can be used to help reduce potassium loss. In severe cases, dialysis may be necessary to remove toxins from the blood and maintain fluid balance until kidney function recovers. Preventing amphotericin B nephrotoxicity involves strategies to minimize kidney exposure to the drug, using liposomal formulations of amphotericin B, which are less toxic than conventional forms whenever possible. Hydrating patients aggressively before, during, and after amphotericin B infusions helps protect the kidneys. Avoiding concurrent use of other nephrotoxic medications can reduce the risk. Close monitoring of kidney function and electrolyte levels allows for early detection and intervention. Dose adjustments based on kidney function can also help minimize toxicity. The prognosis of amphotericin B nephrotoxicity depends on the severity of the damage and the patient's overall health. Mild to moderate kidney dysfunction often improves after discontinuation of the drug and with supportive care. However, severe kidney damage can lead to chronic kidney disease and the need for long-term dialysis. Recent research focuses on developing even less nephrotoxic amphotericin B formulations and exploring adjunctive therapies to protect the kidneys. Studies are also investigating the use of biomarkers for early detection of kidney injury. Early detection and management are critical for improving outcomes.